Yes, you of course.
We went down to the underground,
yeah.
and I was like, I'm going to go see
Yeah,
in
right.
front of everybody.
Right.
They're into this. My parents were like, why
No,
don't you make us
my son and Sleeler are in the same class. It was one of the last
really?
classes where they had the graduation in the garden
Oh, yeah, sure.
under the tent, and
Right.
it was pouring rain, and there was a tent over the stage and a tent over the audience. And so there was a joint of the two tents,
Yeah.
and the water was connected. And we kept waiting for it to land on the D. We were hoping it didn't. But it was, you probably couldn't see that because I was on the stage because I was getting an award. It was really.
That was funny.
Doesn't happen in your armory. So. Anyway, we better keep it in
Oh,
time.
that's funny.
It was part one I put out.
Okay, yeah. Did it? Is that what I'm doing first?
Yeah.
Oh, I have no idea.
Unless you mislabeled.
I have no idea. I just show up.
I normally sit in the back, but I'm going to try to copy some of your lecture techniques.
Oh. Oh, okay. Well, I mean, there's not much of a technique. Sort of walk around up there.
Well, that may be more like what you said. 'Cause I'm not a walker, so I was like, yeah,
Oh, you have to. I like to walk around.
I just stand there like this, being like, I'm trying to look taller, but my feet are killing me.
Your shoes are too tight. Which way?
It should be on. Can you hit the thing and see if it, you know what, there it'll make these like squishy, like weird sounds if you put it where you, like,
Yeah, okay.
it might rub against your
here.
shirt. Oh,
Is it?
yeah, so if you put it maybe on the other,
Where should I put it?
like on the other side.
Yeah, we'll need adjustment. Yeah.
There, then you
Thank
can just
you.
talk into it.
Thank you. I'll be right back. Give me a minute. Get a drink of water. Is there a pointer? Hello? Hello? Yeah, that sounds good.
Okay.
Yeah.
Oh, you put back on.
Okay, super.
All right.
Thanks a lot.
Yep.
Okay. Good morning. Good morning, my fine young doctors. Good morning. Everybody enjoying themselves? You're probably not working hard enough. Okay. Anyway, I'm Dr. McConnell, and here go 2 lectures on the thyroid. The thyroid is a very important endocrine organ, which is located in the lower anterior portion of the neck, just above the collarbone. And under normal circumstances, it's about twice as big as the knot on my tie. Under extraordinary circumstances, it gets pretty big. And this is known as a goiter. Goiter is a term that comes from the Latin word gutter, G-U-T-T-U-R, which means throat. And from whence? Yeah?
Can you flip it on your tie? It's hard.
Okay. That better? I haven't said anything interesting yet. That better? Comes from the Latin word gutter, which means throat, from whence the terms gutter and guttural. This gland produces two iodinated proteins, thyroxine and triiodothyronine, with which we'll become more familiar in a few minutes. And these iodinated hormones are essential for the normal growth and development of the child and the maintenance of a normal metabolism in the adult. A lack of thyroid hormone in infancy and childhood leads to a disorder of neurologic and growth development known as cretinism. And that is a 17-year-old cretin on the right-hand side next to a normal 6-year-old. In adulthood, thyroid hormone deficiency produces the signs and symptoms of hypothyroidism that we'll be discussing in more detail in the next hour and in the small group session tomorrow. Because the thyroid hormones are iodinated tyrosine molecules, basically, I think it's important to begin a study of thyroid physiology with a quick review of iodine metabolism. Because iodine is inhomogeneously distributed around the globe, iodine deficiency is one of the more common of the nutrient deficiency. And it's been estimated that somewhere like 2 billion people are at risk for iodine deficiency in the world, which is roughly 6 times the population of the United States. Iodine is naturally abundant in seawater, and it's concentrated in marine plants and animals, such as kelp, which you see washed up here on a rocky beach. Fruits and vegetables tend to be not so good sources. Where'd it go? No, it's stuck on it. Okay. That's back where it belongs. Fruits and vegetables tend to be poor sources of iodine because they depend on the concentration of the iodine of the soil in which they are grown. And if they come from iodine-deficient parts of the world, they're really terrible sources. The most likely source of iodine that you'll be seeing in the United States is a nutritional supplement. It's put in iodized salt. And this is a advertisement for Morton's salt from the 1920s. And the mother is feeding her children this newly iodized salt, which prevents goiter, which was endemic in the United States up until about 1917. Increasingly, pharmaceuticals are a source of iodine. And this is a short list from the physician's desk reference of iodine-containing medications. So it's mostly nutritionals and pharmacologic supplements. The intake of iodine from natural sources and supplements is somewhere around 250 micrograms a day, which is roughly 5 times the amount that's needed to maintain a minimum of thyroid hormone synthesis. Iodine absorption is a very efficient process. There's a pump in the stomach. And about 20% of the absorbed iodine is taken up by the thyroid, and the remainder is passively cleared through the kidney. So renal excretion of iodine is an important metric for determining iodine sufficiency or insufficiency. Within the thyroid gland, the iodine is used to manufacture the thyroid hormones, a process that can be blocked by a number of other naturally occurring substances, which are known as goitrogens, because they produce goiter. Under normal circumstances, the thyroid contains about 6 milligrams of iodine, which is largely bound to tyrosine as thyroid hormone and its metabolic precursors. Somewhere around 60 micrograms of this iodine is secreted daily as thyroid hormone, which means that there's a very slow turnover of intrathyroidal iodine, maybe 1% a day. And this points up the very large storage capacity of the thyroid gland as opposed to other endocrine organs such as the pituitary, which you heard about yesterday, I think, and the adrenal gland, which you'll hear about next week. So it's a very large storage capacity. Within tissues outside of the thyroid gland, the hormone is metabolized. And it's metabolized largely by sequential removal of iodine atoms, which is known as deiodination. And we'll revisit that concept in a little bit. When the thyroid hormones are deiodinated and metabolized in peripheral tissues, somewhere around 10 micrograms is recycled for thyroid hormone biosynthesis. 15 micrograms goes out in the feces, and another 35 is put out in the urine. These are the proteins found in the thyroid. At the top, you have tyrosine, which is the building block of the thyroid hormones. The next two, monoiodotyrosine and diiodotyrosine, are the intermediary iodinated tyrosines. These iodotyrosines are then linked, or coupled, as we say, to form the mature thyroid hormones. One monoiodotyrosine and one diiodotyrosine are linked to form 3'5-triiodothyronine, which for the rest of your careers you'll affectionately know is known as T3. Two diiodothyronines coupled together form a molecule of tetraiodothyronine, also known as thyroxine, or better as our shorthand T4 for the 4 iodine atoms. Thyroid hormone biosynthesis is a 3-step process. So you can conceptually think of it as 3 steps: iodine transport, oxidation, organification, and coupling, and proteolysis, release, and dehalogenation. Over there on the left, so you'll probably find that out too, because I have to actually look at it and decide which way is right and left. I look at patients so often that it's reversed in my mind. So over there on the left-hand side, we start with iodine transport with a protein known as the sodium iodine symporter, which is the rate-limiting step in thyroid hormone biosynthesis. Now, the symporter is, this iodine transport process is shared not only by the thyroid, but also the stomach, the salivary glands, and the lactating breast, which really points up the origin of the thyroid as a digestive organ. Anyway, the symporter uses energy, ATP, to pump iodine uphill from the serum into the thyrocyte against an energy and electrical gradient. And there's roughly about 30 times more iodine within the thyroid follicular cell as outside of it. Once trapped within the thyroid, the iodine is quickly oxidized and then bound to tyrosine molecules. And these tyrosine molecules themselves are attached to a larger protein known as thyroglobulin. And the thyroglobulin is stored in the lumen of the thyroid follicle as a substance known as colloid. So colloid is the storage form of thyroglobulin. All these steps are catalyzed, the essential steps, the oxidation, organification, and coupling, by an enzyme known as thyroperoxidase. Very important enzyme, which we'll keep coming up as a theme today and tomorrow. And the thyroglobulin in the colloid has a normal T4 to T3 ratio, somewhere about 10 to 1 by weight. In the last step, proteolysis, release, and dehalogenation, the colloid is absorbed into the thyroid follicular cell, where it's acted upon by lysosomes, which cleave the T4 and T3 from the thyroglobulin and release it into the general circulation in about the same 10 to 1 ratio that it's stored. The normal secretion rate of T4 is somewhere around 90 micrograms a day. For T3, it's about 9 micrograms a day. Small amounts of monoiodotyrosine and diiodotyrosine are also cleaved off along with the T4 and T3, but they're not released. Rather, they're deiodinated, and the iodine released can either be recycled for thyroid hormone synthesis or leaked out of the thyroid gland. All these steps in the synthesis release of the thyroid hormones are controlled by a pituitary hormone known as TSH, the thyroid stimulating hormone, also known as thyrotropin. TSH associates with specific membrane receptors on thyroid follicular cells. And these membrane receptors are also the binding site for the etiologic agent of the most common cause of hyperthyroidism, or thyroid overactivity, known as Graves' disease. So the TSH receptor is a very important regulatory protein. And this receptor is attached to adenyl cyclase. So a rise in intracellular cyclic AMP is a necessary early step in thyroid hormone biosynthesis. The iodine comes in to the thyrocyte, thyroid follicular cell, and then it's pumped into the colloid, where the oxidation, organification, and coupling reaction occur, and it's pumped in there by a protein known as pendrin. All these steps in oxidation, organification, and coupling are controlled by the thyroperoxidase, TPO. TSH receptor is heptahelical. It's a single polypeptide chain with 7 transmembrane domains. It has an extracellular TSH binding site and intracellular domain, which is G protein coupled to adenyl cyclase. Gain of function mutations, somatic gain of function mutations of the TSH receptor are fairly common, and they cause a condition known as toxic thyroid adenoma. The toxic thyroid adenoma is a benign tumor of the thyroid gland, which is responsible for about 5% of cases of hyperthyroidism. So, not an uncommon, important somatic mutation. Peripheral metabolism of the thyroid hormones are shown on this slide. Starting over on the left, T4. 100% of circulating T4 is derived from direct thyroid hormone secretion, whereas only 20% of circulating T3 comes directly from the thyroid. Fully 80% of circulating T3 is derived from T4 through the process of monodeiodination, removal of one iodine atom, which occurs in mainly the liver and the kidney. Because the thyroid hormones are highly hydrophobic, the fat-soluble, highly hydrophobic. In order to be transported in the blood, they must be tightly bound to carrier proteins. Bound T4 represents around 99.9% of the total T4 in the blood, whereas the free or unbound T4 is only 0.03%, or thereabouts. 75% of the circulating T4 is bound to a carrier protein known as TBG, the thyroid hormone binding globulin. Please, there's a semantic problem here. TBG, the carrier protein, thyroid hormone binding globulin, is not the same thing as thyroglobulin, which is the storage form of thyroid hormone. So don't get them confused. Right from today, you'll know they're different. 15% of circulating T4 is bound to transthyretin, which also carries the retinol binding protein, and roughly 10% is in the loose association with albumin. Over on the right-hand side, have T3, which is about 99.7% protein bound, 0.3% free. 80% of circulating T3 is bound to TBG, 20% in a loose association with albumin, and there's virtually no binding of T3 to the transthyretin. Although the free or unbound thyroid hormones are quantitatively really insignificant, much less than 1% of the total, it's only the free hormones that can cross cell membranes to interact with intracellular thyroid hormone receptors. The protein-bound hormone is excluded from the interior of the cell. It's a storage form of thyroid hormone. Therefore, please remember that thyroid status is determined by the level of the free, not total thyroid hormones. Let me say it again. Thyroid status is determined by the level of the free thyroid hormones. This is probably the most important thing that I'm going to tell you this morning. So if you want to get up and leave, you've heard the most important thing. But then if you do get up and leave, you'll probably miss a few points that Dr. Garrett will bring up on your exam tomorrow. It's not a joke. Another important point to remember is that the percent free, not the absolute amount, but the percent free of T3 is roughly 10 times that of T4, 0.3% to 0.03%. That means because T3 is more loosely bound to carrier proteins, it's metabolized faster. So the half-life of T3 in the blood is maybe 1 or 2 days, whereas the half-time of thyroxine in the blood is somewhere around 6 to 7 days. Sequential monodeiodination is the prime way that the thyroid hormones are metabolized. Somewhere around 80% of T4 is metabolized by deiodination. There are two enzymes that you have to remember here. Starting over on the left-hand side is an enzyme known as the 5' monodeiodinase. The 5' monodeiodinase removes an iodine from the 5' position on the outer ring of T4, and it forms a compound, 3,5,3' triiodothyronine, which is the major T3 molecule, which is several times as potent as T4 on a weight basis. So you can think of T4 as a precursor hormone to T3, which is the metabolically more active hormone. If you remove the iodine from the inner ring by an enzyme known as the 5' monodeiodinase, you get a hormone known as 3', 5' T3, or it's known as reverse T3. And reverse T3 is important only because it's totally devoid of any metabolic activity. It doesn't do anything. It's actually a metabolic endpoint. So you can think of this monodeiodination point in liver and kidney as being an exceedingly important control point for thyroid metabolism, wherein a precursor hormone, T4, is either activated to T3 or inactivated to reverse T3. There are three functional types of iodothyronine deiodinases in human tissues, and they all require selenium as a cofactor. The role of the type 1 monodeiodinase is to provide plasma T3 for system-wide use, and is found mostly in the thyroid, liver, and the kidney. It's interesting enzyme in that it removes iodine from both the outer and the inner ring. So it has both 5' and 5' monodeiodinase activity. The type 3 enzyme, it provides the intracellular T3 for local use. Once the T3 is formed in the cell, it doesn't get out. And is found largely in the central nervous system, pituitary, and brown adipose tissue. And it has a pure 5' monodeiodinase activity to convert T4 to T3. The type 3 enzyme inactivates both T4 and T3. It's universally distributed, and it has pure 5' monodeiodinase activity. Very jolly ringtone, thank you. Reverse peripheral T4 to T3 conversion occurs in a wide variety of non-thyroidal disorders, which are known as a group as the low T3 syndrome. The low T3 syndrome occurs physiologically in the fetus and in the early neonate, and also in the elderly. So it's like a bookends on our lives that there's decreased T4 to T3 conversion. Pathologically, it's found in starvation, a wide variety of major systemic illnesses, both acute and chronic, and is found also postoperatively. So T3 levels go down postoperatively. Pharmacologically, a number of drugs, propylthiouracil, which is one of the major anti-thyroid drugs, decreases T4 to T3 conversion, as do the glucocorticoids when used in industrial amounts. The nonspecific beta blocker propranolol does it. Certain radiologic contrast agents do it, and so does the antiarrhythmic agent amiodarone. So you've had cardiology, right? Yeah, so you've been familiarized with amiodarone, which is commonly used as an anti-anginal agent and also used to control atrial fibrillation and other tachyarrhythmias. And it decreases T4 to T3 conversion. It's important to remember that this reduced peripheral conversion to T4 to T3 is usually accompanied by normal levels of T4 and TSH. And as far as we can tell, the patients with the low T3 syndrome are clinically euthyroid. Therefore, you think of these people as being sick but euthyroid. And so a synonym for the low T3 syndrome is the euthyroid sick syndrome. And it's reversible. You remove the metabolic stress from the body, you take away the stress dose glucocorticoids, and T3 levels come up to normal. So the reduced T4 to T3 conversion is thought as a nonspecific metabolic adaptation to physiologic stresses. The important corollary here is that sick patients, 75 to 80% of patients next door in the big house have low T3 levels. So sick people have low T3 levels. Therefore, T3 is a lousy test to make a diagnosis of hypothyroidism. I'm not catching any of you guys doing it from here on. So it's a lousy test for making a diagnosis of hypothyroidism because T3 levels are low nonspecifically in illness. The same enzyme, 5' monodeiodinase, that converts T4 to T3 also metabolizes reverse T3 to T2. It's the decrease in this activity, the 5' monodeiodinase activity, that leads to the low T3 in the euthyroid sick syndrome. This also means, because there's a decrease in T3, reverse T3 to T2 metabolism, that reverse T3 levels rise as T3 levels fall. So there's a reciprocity. A decrease in 5' monodeiodinase activity leads to a fall in serum T3 and a rise in serum reverse T3 levels. Thyroid hormone action. Ooh. For about 75 or 80 years, it's been known that when you give thyroid hormone to a hypothyroid animal, there is a general increase in the consumption of iodine by various tissues. Here you have the hours after thyroxine. And after a lag somewhere of about 6 to 12 hours, there's a rise in oxygen consumption through metabolic mitochondrial activity in the whole animal that's shared by most but not all tissues. Spleen, testis, and adult brain, there's no increase in metabolic activity. It's because they lack appropriate receptors. When you use T3 in this system, you find that it has a faster time of onset. It doesn't last as long, and is somewhere around 3 to 4 times as potent. Same thing happens in humans. T3, on a weight basis, is 3 to 4 times as potent as T4, has a faster onset, and a shorter duration of action. This is, it's like Pac-Man, doesn't it? Anyway, this is, you all remember Pac-Man, right? Yeah, I think it's making a comeback. Anyway, thyroid hormone, T3, interacts with membrane receptor sites in various tissues. Now, how the T3 gets into tissues is unclear. But what is clear is that it requires energy, and it's linked to the aromatic amino acid transporter, which also transport a number of aromatic amino acids. It's tyrosine, phenylalanine, but you don't have to know that, at least from my lectures. Anyway, once it gets into the cell, the cytosol, the T3 is bound very loosely by cytosol binding proteins, the CBPs, which don't have any effect on thyroid hormone action, except that they may restrict thyroid hormone activity by soaking up extra T3 in the cells, but that's not entirely clear. What is clear is that there are very specific and high affinity binding sites for thyroid hormones on intermitochondrial membranes. And the receptor activity, the highest density, are in tissues that respond to thyroid hormone by increasing oxygen consumption, and the lowest density in tissues which don't increase oxygen consumption. Nuclear receptors. Nuclear receptors are the primary site of thyroid hormone action. The receptors bind T3 about 10 times as avidly as they bind T4. And a corollary here is that 90% of thyroid hormone metabolic activity is due to T3, only 10% due to T4 because of the lesser nuclear receptor binding. And these receptors control DNA transcription with messenger RNA production. So nuclear receptors, the prime site of thyroid hormone action. And this is what the receptors look like. You've probably seen it a zillion times before. There's homologies between the T3 receptor and other receptors such as the glucocorticoid and estrogen receptors. On the left-hand side, in purple, you have the cysteine-rich DNA binding domain. On the right, you have the ligand binding domain. And these are connected by a hinge region. The thyroid hormone receptors associate with specific DNA sequences known as hormone response elements, which are located near the transcription start point of the target gene. The receptor binds either as a homodimer or more commonly as a heterodimer with the retinol X receptor. The hormone, the receptor complex on the DNA is bound in the absence of hormone. So if there's no hormone, it's bound to a co-repressor protein. Once thyroid hormone gets in the cell, the co-repressor comes off the hormone, the receptor complex, so there's a dissociation of co-receptor. There's a recruitment of co-activator and RNA polymerase, which leads to an alteration in the rate of transcription of the target gene. That's the way it works. Without hormone, you have a co-repressor. Hormone binds, the co-repressor comes off. There's a recruitment of a co-activator and RNA polymerase, and then there's an alteration of the target gene. Thyroid function, yes?
You had mentioned that the 5' monoiodinase,
Yeah.
the other one are in the liver and the kidney.
Right, primarily.
So is it that the circulating T4 is taken into those cells, converted, and then
T3 comes out. Yeah, T3 comes out. Yeah, T3 comes out and the T4 is all gone. Actually, some of it goes, about 15% goes out in the bile.
So this is intracellular, intracellular conversion, and then it's excreted.
That's correct. Then it's rebound. Yeah. So the free goes in, it's metabolized, comes out, rebound, and it's carried to organs where it does its thing by binding to nuclear receptors. Exactly correct. Thyroid function is controlled by 3 organs, which function together in a classic example of negative feedback inhibition. The hypothalamus, the anterior pituitary, and the thyroid gland. Hypothalamus produces a simple tripeptide known as TRH, the thyrotropin or TSH releasing hormone. TRH is secreted into the hypothalamic pituitary portal system. And in the pituitary, the TRH binds to specific receptor sites on the thyrotrope. The thyrotrope in the anterior pituitary are those cells that produce TSH, the thyroid stimulating hormone, and release TSH into the general circulation. TSH binds to specific membrane sites on thyroid follicular cells and working through the adenyl cyclase cyclic AMP system, controls all the steps in the synthesis and release of the thyroid hormones. In the blood, the thyroid hormones are largely protein-bound. Less than 1% is free or unbound, and it's that less than 1% of thyroid hormone that is responsible for tissue action. Also, the less than 1%, circulates back to the anterior pituitary and shuts down TSH production. So it's a negative feedback loop. T3, which is largely derived from T4, is about 10 times more effective in negative feedback inhibition than is T4. So T3, once again, the much more potent thyroid hormone, shuts down TSH production at the level of the pituitary, not the hypothalamus. Unlike the simple tripeptide TRH, TSH is a big glycoprotein molecule, about molecular weight about 28,000. And it has two parts to it, an alpha chain and a beta chain, which gives it homologies with, of all things, the gonadotropes, the gonadotropins. So it has, TSH has homologies to luteinizing hormone, follicular stimulating hormone, and human chorionic gonadotropin. It's also interesting that the TSH receptor is promiscuous, as is said, and that it can be stimulated by other hormones, not only TSH. Human chorionic gonadotropin in high concentration activates the TSH receptor and increases production of thyroid hormones. So, who can tell me what common physiologic condition you find the highest levels of human chorionic gonadotropin? Pregnancy, exactly correct. There's an obligatory increase in thyroid hormone production during, see how easy medicine is? There's an obligatory increase in thyroid hormone production during pregnancy, and this is stimulated not by TSH, but by the human chorionic gonadotropin. So it's HCG that stimulates thyroid hormone production, which is obligatory for maintaining a normal pregnancy. Under physiologic conditions, the most important control on TSH blood levels is the free T4 and also the free T3, but what we have is the free thyroid hormones. Here you have this negative feedback inhibition in a graph form. You have plasma TSH plotted against free thyroxine levels. At pathologically low levels of free thyroxine that one would find in decreased production of thyroid hormone by the thyroid gland, hypothyroidism, TSH levels are elevated. As free T4 levels increase towards the right, TSH levels fall sharply. And through the physiologic range of free T4, TSH is normal. When you get into the supraphysiologic range of free T4, TSH falls below normal and eventually becomes immeasurable as the pituitary is shut down. And this happens when there is autonomous production of thyroid hormone by the gland in hyperthyroidism. And it's this curve which makes TSH the single best screening test for thyroid dysfunction. Blood levels of thyroid hormone can change in either of two basic ways. Changes in thyroid gland secretion, as in hyper and hypothyroidism, and changes in the level of the binding proteins, which occur very commonly. At the top, you have an increase in total T4 measurements, and largely T3 parallels these changes, except when patients are sick. Total T4 measurements are increased in hyperthyroidism, where you have autonomous production of thyroid hormone by the gland, and there's an increase in the total and the free T4 levels. And of course, it's the free T4 which makes the patient hyperthyroid, not the total T4, because the total T4 don't cross cell membranes. Elevated levels of the thyroid hormone binding globulin increase the total T4, but the free T4 is normal. So these patients are euthyroid. An elevated TBG occurs uncommonly as an X-linked dominant. It occurs very commonly in pregnancy, which is probably the most common time you'll see a high total T4 level. Acute liver disease, that's where TBG is produced in the liver and is released by acute necrosis of the hepatocytes. And certain drugs, such as estrogen and the selective estrogen receptor modulators, tamoxifen and raloxifene, also increase TBG levels. And during pregnancy, parenthetically, it's the high estrogen which leads to the increase in TBG production. At the bottom, total T4 measurements are decreased in hypothyroidism, so destruction of thyroid tissue. There's a decreased total and a decreased free T4. So the patient is hypothyroid because free T4 levels are low, not because the total T4 is low. It's the free T4 that determines thyroid status. Decreased TBG with a decrease in total and normal free T4 can be seen congenitally. It's also seen in acromegalic patients with excessive growth hormone production. In the nephrotic syndrome, the leaky glomerulus puts out TBG into the urine. Chronic liver disease, say an alcoholic cirrhotic, will have low TBG levels and low total T4 levels because of decreased production rates, and also androgens and glucocorticoids in pharmacologic amounts will decrease TBG production. Number 3 is important because any patient who is taking T3, triiodothyronine, will have low T4 levels. That's because the T3 feeds back on the pituitary, shuts down TSH, and decreases T4 production. So any patient taking T3 exogenously will have low serum levels of T4 because of decreased production. But of course, they're euthyroid because they're taking the T3. In acute medical illness, ICU class patients, the free T4 level is typically low. The total T4 level is typically low. The free T4 level is variable, and it's variously been reported to be high, normal, or low. Don't have to worry about that. Just know that total T4 can, or acute medical illness can depress the total T4. Okay. The mysteries of the T3 resin uptake, which conceptually tends to be one of the more confusing parts of thyroidology. The total T4 can change either because of changes in thyroid hormone secretion by the gland or levels of the binding proteins. And just by looking, say, at a high or low total T4, you can't tell whether it's secretion that's decreased or increased, or whether it's changes in the level of the binding protein. What you are interested in, and should be interested in, is the free T4, because the free T4 defines thyroid status. How do you get from the total T4 to the free T4? It's very simple. You multiply by the percent free thyroid hormone, which is less than 1%. Now, it's easy to say that, but it's hard to do it because measuring the percent free thyroid hormone is a technically difficult process. Because it's technically difficult, there have been developed cheaper and simpler tests known as thyroid hormone binding ratios. These thyroid hormone binding ratio tests correct the total T4 for changes in the levels of the binding proteins. The thyroid hormone binding ratios are proportional to the percent free T4. When the percent free T4 goes up, thyroid hormone binding ratio goes up. When the percent free T4 goes down, thyroid hormone binding ratio goes down. You multiply the total T4 by the thyroid hormone binding ratio, and you get a number that's known as the free T4 index, the FTI, which is typically proportional to the true free T4. The most commonly used thyroid hormone binding ratio is the T3 resin uptake. On the left, you have a molecule, you have TBG. And TBG, the thyroid hormone binding globulin, has bound thyroid hormone in yellow and a lot of free, unsaturated binding sites up at the top in white. The way the T3 resin uptake is done is that radioactive T3 is added to an aliquot of the patient's serum, and the radioactive T3 binds preferentially to the empty, unsaturated binding sites on the thyroid hormone binding ratio. The thyroid hormone binding globulin. The hot T3 that's left over and not bound, because there's only a finite number of binding sites on TBG, is then soaked up by a resin. It's thrown into the test tube. The percent uptake, the T3 resin uptake is the counts on the resin over the total counts added times 100. And it's usually around 30%. This is how it all works. Conceptually, this is what you should be thinking. You have 5 states there. Starting from the right, starting from the left, you have normal, hyperthyroid, hypothyroid, low TBG, and high TBG levels. Let's take it one by one. Normally, the total T4 is normal. The T3 resin uptake is normal. And when you multiply the two together, you get a normal free T4 index. In hyperthyroidism, due to increased autonomous production of thyroid hormone from the thyroid gland, with secretion of all this hormone into the bloodstream, the hormone is taken up and bound by the TBG, which is, circulates in normal levels. But because of all this hormone production, the free binding sites on TBG are restricted. Therefore, when you do the T3 resin uptake test, because of this restriction, you add the hot T3, there's less that can be bound to TBG, and more is taken up by the resin. So the resin uptake goes up. That means the percent free of thyroid hormone is actually higher than normal. And when you multiply this high total by a high percent free, you get an elevated free T4 index, which reflects truly the increase in free T4 levels, which are characteristic of hyperthyroidism. Conversely, in hypothyroidism, say if you remove the thyroid gland with normal levels of the thyroid binding proteins and normal levels of T3, because of the decrease in production, total T4 levels are low. And because of expansion, there's more free sites on the TBG. When you add the hot T3, it binds preferentially to these unsaturated binding sites, less binds to the resin, and the T3 resin uptake is depressed. And when you multiply a low total T4 by a low T3 resin uptake, which reflects the percent free of being low, you get a low free T4 index. So you know the patient's hypothyroid. In the case of a low TBG, say cirrhotic liver disease, there's less TBG produced. Therefore, the total T4 levels are going to be low. It's because you can think of it, you take a cylinder of TBG and you sort of compress it. And what happens is that the hormone that's bound to the T4 binding sites is flipped off into the circulation. So you end up, because of these restricted binding sites, with a low total T4, but there's a high percent free. Bounces off. So the percent free goes up, the resin uptake goes up. When you multiply a low total T4 by a high percent free or the T3 resin uptake, you get a normal free T4 index. So you know the patient's euthyroid. In pregnancy, there's an expansion of TBG. Happens then is that there's more room for the T4 to bind, so it binds in there. So the total T4 goes up, but what happens is that there's there's also more room, more unsaturated T4 binding sites on this expanded TBG. So when you add the hot T3, the resin T3 uptake is low because there's more sites on the TBG, and that's where the T3 is binding preferentially. So you end up in pregnancy with a high total T4, a low percent free, a low T3 resin uptake, and when you multiply a high total by a low T3 resin uptake, you get a normal free T4 index, and so your pregnant woman is euthyroid. When the total T4 and the resin T3 uptake move in the same direction, they're both going up or they're both going down, it's a problem with thyroid hormone secretion. When they move in opposite directions, it's a change in the binding proteins. Got that? So they move in the same direction, up or down. It's a problem with thyroid hormone production. When they move in opposite directions, it's a binding protein anomaly. And in this case of the binding protein anomaly, the T3 resin uptake is correcting the total T4 for the changes in the binding proteins, either up or down. Finally, TSH. TSH, single best screening test for thyroid gland dysfunction. Compared to normal euthyroid individuals, patients with hyperthyroidism, which can be produced either by excessive thyroid hormone secretion from an overactive thyroid gland, or by a patient taking excessively high doses of thyroid hormone, the TSH levels are suppressed. They're low and often are immeasurable. So low TSH equates with hyperthyroidism. It doesn't matter whether it's endogenous overproduction or exogenous hormone use, TSH is suppressed. In the case of decreased thyroid hormone production by the thyroid, the pituitary is released from negative feedback inhibition, and TSH levels go up. An elevated TSH is single best screening test for primary hypothyroidism. That is, primary is due to destruction of thyroid tissue. So elevated TSH equates with hypothyroidism. In the case of pituitary or hypothalamic insufficiency, for whatever reason you learned about yesterday, destruction of the cells or interference with the action of the thyrotropes of the pituitary leads to a hypothyroid patient with a low TSH. So in secondary hypothyroidism, TSH levels are either low or inappropriately normal. So get this concept. It's inappropriately normal. Yes, they may be normal, but if the patient is hypothyroid, it's inappropriate. If the hypothalamus or pituitary was functioning normally, the TSH would be up, but it's not. It's low. So the patient has secondary hypothyroidism. Let's take a break. Take a 5-minute break or so. Come back and let's do hyper and hypothyroidism. And I'll stay down here in case anyone has any questions.
just put the next step. I don't know.
Could you explain the normal TSH levels during secondary hypothyroidism? I get why they would be low, but normal seems weird if it's a secondary condition.
It's inappropriately normal.
Mm-hmm.
You'll find that many patients with a pituitary
Mm-hmm.
that's impinging on the thyroid will not be able to produce enough TSH to keep the thyroid healthy. You think of it that the patient is hypothyroid, clinically hypothyroid is low 3T4 levels, but because if the low 3T4 was due to destruction of the thyroid, TSH would be elevated.
Right, so that would be primary.
If the thyroid stroke was normal, the fact that the TSH is not elevated means that there's thyroid stroke dysfunction.
Okay.
It's inappropriately normal. I know it's a hard concept, but it's an important concept.
So in that setting, would you then be thinking about a inappropriate reaction from the thyroid gland to TSH? Because wouldn't the normal levels of TSH be causing normal secretion of thyroid hormone?
That means that whatever that TSH level is lower than the thyroid needs to produce normal amounts of thyroid hormone.
Okay.
Even though it's normal, it's the thyroid needs a higher degree of stimulation to get normal levels of thyroid hormone.
So what confuses me there is then that sounds more of a primary issue with the thyroid gland.
Say you have this patient, secondary hypothyroidism, normal TSH, you inject TSH, say you inject TSH, this synthetic TSH.
Mm-hmm.
You inject synthetic TSH, you see a sharp increase in thyroid hormone production in the normal diet. You pop right up. And then you don't do it that often because we know enough that TSH will be met in cases of secondary hypothyroidism. And so it's not always normal. You think it would be, but it's not always. It's inappropriately normal.
Yeah.
I know it's confusing.
Yeah, it just doesn't explain. It doesn't explain to me why then the thyroid in that setting needs more TSH.
We all have a set point for TSH. All extent that every human being has a different set point for TSH that keeps thyroid hormone production.
Okay, and so is it?
So my TSH is different than yours.
Right. And so is it just that it happens to fall within what we accept as a normal range, and maybe there's been a new set point placed on this? Okay. Okay.
That it's within the accepted 95% confidence levels for TSH, but it's lower than that thyroid gland would like than
Gotcha. Okay. Thanks.
Okay? You're welcome. What's up?
I was wondering why in liver cirrhosis you would get a decrease for the second last line of the show.
Because of decrease in thyroid hormone binding globulin production.
Okay, so yeah, I understand. So your liver produces that protein. You're not making it anymore. How does that alter the T4 levels? The total T4.
The total T4. Okay. So the production rate of PBG goes down.
Yes.
So the PBG levels are lower than normal. But the thyroid is normal.
Yes.
The thyroid, hyperthyroid, pituitary axis are normal. So the thyroid is putting out T4.
Same amount as.
Same amount as always. You're restricting the unsaturated binding sites on PBG, so you can think of compressing the cylinder. That displaces T4 from the PBG, which is then converted to T3, which touches on TSH, and production rates of thyroid hormone fall at a new set point.
Oh, okay. So then, would you expect it to increase in T3 because you have a greater proportion
It's in the, yeah.
T4?
There is an increase in T3, but it's so minuscule because actually it's only transient.
Right.
It's transient.
Because
Once
the set point resets.
sets itself, and then the system comes back into an equilibrium.
Okay, so all that residual T4 that we previously had been bound is converted to T3
And then metabolized.
Don't you need a liver though to convert it to T3? So cirrhotic liver can still do the conversion?
It can do the conversion, not as well, but it does the conversion.
Okay, great.
I think that was my question too. Actually, I was confused on this slide how, like, elevated TBG leads to normal. Like, wouldn't if you have more TBG, you would have less free T4. Was like my logic around that.
Yeah, that's correct. But the TBG is increased, and so you have a higher total T4, but a less percent free. It's because you're expanding the cylinder. Expanding the cylinder here, and the total TBG increases, the total T4 increases,
But then why do you have normal free T4 then if you have more?
Because the percent free goes down.
Okay.
The T3 resin uptake will go down. So you can think of it this way: that say you're expanding the amount of the thyroid hormone binding property. Instantaneously, the free T4 will actually fall. That stimulates the pituitary
Right.
to increase thyroid hormone from the thyroid gland.
Right.
And then that thyroid hormone fills up the free sites on TBG until you get to a normal free T. It'll bring the free T4 back up to normal.
Okay.
Okay, but the percent of TBG that's free or bound is actually lower than the percent, not the absolute percent. That's why you did the conversion.
Okay. Thank you.
The percent is lower, so it's less than 0.02%.
I just want to say hi. I came to see you. I'm the super good to see you in November.
Oh, you did?
Yeah.
Oh,
Only
okay.
once.
I was just confused about this, like how you have getting more TBG gives you like normal free TBG. So I would think that the more TBG you have, and the more T4 is down, and the less free. He was explaining that. I need to think it through a little bit more. Yeah.
Yeah, it's confusing. I hear you. I hear you. Why this happens is unclear. It's something of the protective mechanism. So you crank down T3 production rates and 6 protect the body, and then the T3s come back to normal. Okay. You're welcome. Okay. 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 It's
get going here. Dr. Garrett says we have to go. I know you're all very excited by my first lecture, but we have to get out of here at 11 o'clock. So let's talk about hyper and hypothyroidism. A lady, age 20, became affected with some symptoms which were supposed to be hysterical. Her pulse had become singularly rapid. She complained of weakness on exertion and began to look pale and thin. It was observed that the eyes assumed a singular appearance, for the eyeballs were apparently enlarged, and in a few months a tumor of horseshoe shape appeared on the front of the throat and exactly in the situation of the thyroid gland. Dr. Robert J. Graves, 1835. This is Graves. This is probably what his patient looked like. Graves' disease. Graves' disease is a multi-systemic disorder that is far and away the most common cause of hyperthyroidism. It is about 5 times as common in women as in men, and the peak age incidence is in the 20s and 30s, about your age, your demographic. It's a triopathy of a diffusely enlarged thyroid, which you really can't see down there, in 100% of patients. Prominent eyes, characterized by usually with edema, periorbital edema, and prooptosis, or the eyes going forward, in somewhere around 40% of patients. And about 5% of patients will have an indurated podarage pretibial myxedema. That's pretibial myxedema. Elderly patients, or my demographic, will have an apathetic appearance. They often appear to be apathetic, and this is because they lack the hyperkinetic signs and symptoms of thyroid overactivity typical of younger people. So this is known as apathetic thyrotoxicosis. The patients will lose weight. They will often be very weak, and they'll have a cardiovascular dysfunction. Very commonly, they'll have either angina pectoris, a tachyarrhythmia, or congestive heart failure. So it's weight loss, weakness, and a cardiac dysfunction, which is typical of older people with Graves. Graves' disease, like other thyroid disorders, typically runs in families, with children inheriting a predisposition to develop the disorder from their parents. But not every family member is involved. And it's widely recognized that environmental factors are also important. One of the important environmental factors, this young man sitting here with a severe retro look obviously has some sort of a psychological dysfunction. Sister Jan is probably telling the family that she's pregnant because that's also another risk factor. And this little guy is a closet smoker, and that's even a bigger risk factor for developing autoimmune thyroid diseases. The autoimmune thyroid, the Graves' disease, is caused by large globulins, thyroid-stimulating globulins, the TSH receptor antibody, directed against the TSH receptor. It binds to, at the bottom, the extracellular domain of the TSH receptor, just as does native TSH. And the TSH receptor antibody is responsible for the overproduction of thyroid hormone and also for the growth of thyroid tissue. On the right-hand side, you have a Graves gland, which is about 3 or 4 times normal size of a normal thyroid gland. So not only does the TSH receptor antibody increase thyroid hormone production, but it also makes the gland grow. Thyroid eye disease, also known as ophthalmopathy, I mean, it has a number of different names: thyroid eye disease, ophthalmopathy, or thyroid orbitopathy. Same difference, different synonyms. So thyroid eye disease. Yes, this is bad, but this guy got better. Actually, he got all cured of his thyroid eye disease. Okay, so that's the happy end to the story. In the end, it's not so happy because he ended up dying of myasthenia gravis, which is another autoimmune disorder. All these autoimmune disorders tend to travel in packs. Okay, so he got better from his Graves and his eye disease, but the end, myasthenia got him. Anyway, thyroid eye disease and the pretibial myxedema are closely related autoimmune disorders that are not due to thyroid hormone excess. Non-autoimmune causes of hyperthyroidism, such as toxic adenoma or toxic multinodular goiter, are not associated with either thyroid eye disease or with the pretibial myxedema. It's only the autoimmune thyroid disorders that are associated with the thyroid eye disease. And this is the CT scan of that gentleman. The left orbit that's involved with a severe chemosis where the heaped up conjunctiva is over on the left-hand side. In the other orbit on the right, of course. And what you'll see is that the left eye is pushed forward due to expansion of the retroorbital tissues. This expansion of the retroorbital tissues is primarily due to expansion through deposition by hydrophilic glycosaminoglycans in the retroorbital tissues. They soak up water, expand, and also by fat proliferation. The fat cells proliferate. The antigen responsible for this autoimmune disorder is probably, of all things, the TSH receptor. Why the TSH receptor should be expressed in retroorbital tissues, primarily on fibroblasts and preadipocytes, is totally unknown. But this TSH receptor is stimulated by both lymphocytes and also circulating thyroid-stimulating immunoglobulins. And with expansion of retroorbital tissues, the globes are pushed forward. You get the proapoptosis. There's decrease in vascular outflow from the orbit, and so you get the periorbital edema and the buildup of the edematous conjunctivae, which leads to the chemosis. The toxic diffuse goiter, Graves' disease, has a female-to-male ratio of about 5:1, peak age, year demographic, 20 to 30s, whereas the eye disease, which occurs in about 40% of patients with toxic diffuse goiter, has a lesser female-to-male ratio. It's about 2:1 instead of 5:1. And the peak age is backloaded, is more in the 40s and 50s than in the 20s and 30s. The major risk factors are cigarette smoking, which increases the odds or hazard ratio of getting Graves' eye disease by a factor of 8 to 10. And also possibly radioactive iodine therapy, which is used commonly as the first-line treatment of Graves' disease. The therapy of hyperthyroidism, our goals are several. So we're going to treat this patient. First goal is to decrease the circulating levels of thyroid hormones, either through destruction of thyroid tissue, primarily radioactive iodine surgery, or pharmacologic means that reduce synthesis and release of T4 and T3 from the gland, or reduce the peripheral conversion of T4 to the metabolically more active hormone T3. Secondary goal, the patients will appreciate, is to ameliorate the symptoms of the hyperthyroid state. And finally, what we'd like to do, what we're not so good at, is to correct the underlying pathologic process, because we just don't have that granular control of the immune system that we would like. And maybe one of you sitting out there will be the person to discover how we do this. Thyroid hormone biosynthesis is a three-step process. And each of these steps has its own unique inhibitors. Iodine transport by the sodium iodine symporter can be inhibited by two monovalent anions, thiocyanate and perchlorate. The thiocyanate is a naturally occurring substance that potentiates environmental iodine deficiency by competitively blocking the symporter. And perchlorate has been used as an anti-thyroid drug, but it's little used these days because it was found to form or cause agranulocytosis, which you probably remember from hematology is a rather inconvenient side effect of a pharmaceutical. The major anti-thyroid drugs are known as the thiouracils, or more commonly the thioureas in the United States. The thioureas competitively inhibit the thyroperoxidase, which is the enzyme important in oxidation, organification, and coupling. And it's important to know that although they competitively inhibit the peroxidase acutely, there's still preformed hormone in the gland that is not affected by the anti-thyroid drugs. And so it's a delayed effect. You block the peroxidase today, the patient's thyroid hormone levels aren't going to be normal until the 22nd of June. It's a delayed effect. This is the anti-thyroid medications, the major ones, propylthiouracil and methimazole. They're heterocyclic compounds, and they both contain a thiourea group. Intrathyroidally, they inhibit incorporation of iodine into tyrosine, and they inhibit the coupling of monoiodotyrosine and diiodotyrosine to form T4 and T3. And they do this through competitive interference with the thyroperoxidase. They also have extrathyroidal effects in that they reduce the titers of the thyroid-stimulating immunoglobulins through unclear means. But by decreasing thyroid hormone production, the thioureas decrease the signaling of the thyroid follicular cells to the immune system and decrease or at least attenuate the autoimmune process. Propylthiouracil, as I've mentioned last hour, reduces the peripheral conversion of T4 to T3, typically at higher doses. And this gives propylthiouracil a competitive advantage as opposed to methimazole because it lowers T3 levels faster. And in patients who are severely hyperthyroid, we often use PTU instead of methimazole because of this effect to decrease T4 to T3 conversion in liver and kidney. Both PTU and methimazole are absorbed from the GI tract with an absorption peak of about an hour or two. And they're both concentrated in the thyroid gland. However, methimazole has an advantage in that its half-time in the circulation is 4 times as long as PTU, and its duration of action is twice as long. So wherein PTU is administered 3 to 4 times a day, methimazole can be administered once a day, and it increases compliance. For this reason, along with another reason that we'll talk about in a few minutes, methimazole is the preferred thiourea. PTU is much more highly bound than is methimazole. And when you look at the typical starting dose, you see that methimazole gets more bang for the buck. That its starting dose is about 1/15 that of propylthiouracil. So methimazole is the preferred thiourea. The anti-thyroid drugs are used as primary therapy for Graves' disease and also in preparation for definitive treatment with radioactive iodine or surgery. The anti-thyroid drugs are not the primary therapy for the non-autoimmune hyperthyroid disorders such as toxic adenoma and toxic multinodular goiter. That is because toxic adenoma and toxic multinodular goiter are not autoimmune causes of hyperthyroidism. So they're not caused by the TSH receptor antibodies. They won't remit for no matter how long you treat them with the antithyroid drugs. They have to be treated definitively with either radioactive iodine or surgery. So, first off, primary therapy for Graves' disease. The antithyroid drugs, preferably methimazole, are adjusted every 2 or 3 months with the goal of keeping the thyroid hormone levels normal. The usual course of therapy is anywhere from 6 to 18 months. After 18 months, if the patient has not remitted, gone back to normal on the antithyroid drug, the chances of their remitting are vanishingly small, and so we typically move on to a definitive therapy, radioactive iodine or surgery. The remission rate for after 6 to 18 months of antithyroid drug is significant but somewhat variable. Usually, if you can get 50% of patients remitting, you're doing pretty good, which means 50% will relapse. And this is the percent of patients remaining in remission months after the end of treatment. Somewhere around 1/3 of patients with Graves' disease will go back to hyperthyroidism within the first 12 months. But if you follow out long enough, you find that there's a fall off, and maybe at the most 40 to 50% of patients will have a long-term remission, which means that somewhere like 50 to 60% won't. They'll either have to go back on the antithyroid drug or preferably go to radioactive iodine or surgery. The antithyroid drugs are also used for pre-definitive therapy with with either radioactive iodine or surgery because they blunt the release of thyroid hormones after radioactive iodine. When you give radioactive iodine to patients, you expect them to release thyroid hormone because you get necrosis of the thyrocytes. The radioactive iodine is taken up into the thyroid follicular cells, it kills them, and whatever hormone's in the gland is released. Usually for young people, this is not a big deal. But you get someone of a certain age, like me, who has maybe a little coronary plaque, and that excessive thyroid hormone release can overstimulate the cardiovascular system and lead to inconvenient cardiac side effects. So we typically pre-treat patients over the age of 50 before they get the radioactive iodine. Also, the pre-treatment reduces the risks associated with thyroidectomy on an untreated hyperthyroid patient. Prior to the routine use of antithyroid drugs, thyroidectomy, removing the thyroid gland in patients with Graves' disease, was a 50-50 proposition. 50% of the patients would die. And remember, these were young women. These are typically young women. And the reason they would die is that all this thyroid hormone released from the gland would overstimulate the cardiovascular system and lead to a condition known as thyroid storm. So these days, we pre-treat the patients, make them euthyroid, and then go to surgery or radioactive iodine. Important side effects of the thioureas are listed here. Transient decrease in the white blood cell count, which is not a harbinger of agranulocytosis, occurs fairly commonly, upwards to 25% of patients. Skin rash can occur, 10%, and liver dysfunction with inflammation of the liver, acute hepatitis, occurs in about 6%. Hepatocyte necrosis, which is severe enough to lead to hepatic transplant, can occur in about 0.1% of patients treated with propylthiouracil, especially children and adolescents. This side effect of hepatocyte necrosis has led to a black box warning for PTU. And so PTU is not recommended as the first-line thiourea therapy, especially on anyone under the age of 20. So use methimazole instead. Methimazole can cause cholestatic jaundice, but it has been associated with hepatocyte necrosis, so it's our first-line drug. Not only does it last longer, but it's less hepatotoxic, and that's why methimazole is used, except with a singular exception, someone who is severely thyrotoxic in the intensive care unit with thyroid storm may be treated with PTU to get the T3 levels down more quickly. Arthralgias occur maybe in 5% of patients, and wiping out the white blood cells, which typically occurs in the first 3 months of therapy, occurs in maybe 0.5% of patients. There appears to be a dose effect with methimazole, meaning that higher levels of methimazole, above 20 milligrams a day, are more commonly associated with agranulocytosis than lower doses. That's why we start with 20. Whereas in PTU, there's not this dose effect. The most important inhibitor of proteolysis release and dehalogenation is iodine, of all things. So iodine not only is an integral part of the thyroid hormone, it also has antithyroid effects. Go figure. Iodine blocks the secretion of preformed thyroid hormone. So it's useful in acute situations where rapid control of hyperthyroidism is essential, such as patients with thyroid storm. And it also reduces blood flow to the gland. And that's why you'll see on your surgical rotation, patients coming in for thyroidectomy for Graves' disease will be treated with a high dose of iodine to decrease the vascularity. Lithium, like iodine, blocks secretion of preformed thyroid hormone from the gland, and that leads to an increased radioactive iodide retention and prompter control of hyperthyroidism after administration of the therapy dose. The symptomatic relief of the hyperthyroidism, usually we use beta adrenergic agonists such as propranolol to treat the anxiety, the tremor, the palpitations, which are typical of the hyperthyroid state. And propranolol will also decrease T4 to T3 conversion, which has another therapeutic advantage of using this medication to alleviate symptomatic hyperthyroidism. The calcium channel blockers are useful in patients who cannot tolerate beta blockers, or when beta blockers are contraindicated, such as asthmatic patients. So a severely asthmatic patient, you use a calcium channel blocker for symptomatic relief and not the beta blocker. Radioactive iodine is typically our first-line therapy for hyperthyroidism in the United States, and somewhere around 80% of patients ultimately will receive radioactive iodine to kill their thyroids. In other parts of the world, such as Europe and in Asia, radioactive iodine is not so commonly used, and patients in those parts of the world are more commonly treated either with antithyroid drugs, or if they need definitive therapy, the patients will be taken for thyroidectomy surgery. There are certain concerns with radioactive iodine therapy. Teratogenicity and long-term genetic damage. The findings are that as long as your patient is not pregnant, the radioactive iodine doesn't cause any problems with long-term genetic damage. It does not cause neoplasia anywhere else in the body. It does not cause thyroid cancer, and it doesn't cause infertility. What it may do, besides killing the thyroid and getting to your expected therapy endpoint, which is hypothyroidism. That's what you want is a hypothyroid patient. I say, why do you make the patient hypothyroid? So you're trading in an overactive gland, and you got yourself an underactive gland at the back end, right? It's because thyroid hormone is a lot safer, cheaper, simpler to use than the anti-thyroid drugs, because in therapeutic amounts, thyroid hormone has virtually no side effects. It's also much safer, it's much cheaper. Patients don't have to come back but once a year to have their thyroid tested, not every 2 or 3 months. So that's why hypothyroidism is preferred to hyperthyroidism. And there is a question of exacerbation of thyroid eye disease. It has not been clearly adjudicated, but there is at least some evidence that patients with Graves' disease and active eye disease, the eye disease gets worse after they take radioactive iodine therapy. The thinking is that releasing thyroid antigens into the bloodstream stimulates the immune system. And remember, there's a TSH receptor in retroorbital fibroblasts and fat cells, and becomes fair game for a stimulated immune system. Surgery. Surgery, thyroidectomy, is the oldest form of therapy, but we use it selectively now. We reserve it for special circumstances, such as a pregnant woman who fails anti-thyroid drugs. Of course, you don't use radioactive iodine in pregnancy. That's a big no-no. And if the anti-thyroid drugs are used in pregnancy, you also have to know that they cross the placenta, and they can lead to a hypothyroid fetus, which can lead to developmental abnormalities. And so if a pregnant woman fails low-dose anti-thyroid drug, they're typically sent for surgery, usually in the mid-trimester. If the patient has active eye disease, severely progressive thyroid eye disease, such as the gentleman I showed you a few slides ago, and he needs definitive therapy, you're going to take him to surgery and not give him radioactive iodine, which could worsen his eye problem. And if there is suspicion of thyroid cancer, every once in a while, a patient with thyroid overactivity, hyperthyroidism, there may be a suspicion of cancer along with either Graves' disease or toxic nodular goiter, and you send them for surgery and not give them radioactive iodine. The risks of surgery are several. Typically with an experienced surgeon, they're low risk. Recurrent laryngeal nerve damage and damage to the 4 parathyroid glands, which are near the thyroid, happen maybe 2 or 3% of cases. So it's a 2 or 3% morbidity. Recurrent laryngeal nerve damage or hypoparathyroidism. But it's real. I mean, it's real. Rod Stewart, the rocker. Yeah. It's no secret, he had a thyroidectomy, and it did affect his voice. So it's a real complication. Hypothyroidism is the expected therapeutic endpoint. You expect the patient to be hypothyroid after you take their thyroid gland out, then you put them on thyroid hormone for the rest of their life. Speaking of hypothyroidism, here's our hypothyroid lady showing up again. Dull, apathetic faces. I mean, you can almost feel the dryness of her skin and hair. There's a certain sallowness. I mean, she has it's not just the slide or the flash. There's a certain sallowness to her skin, a pale yellow color. Typical of hypothyroid patients, severely hypothyroid patients. Causes of hypothyroidism, pretty much 50% autoimmune and iatrogenic. Basically, iatrogenic means what you guys are going to be doing to your patients. The most common autoimmune cause is Hashimoto's disease. which is named after Dr. Hakuru Hashimoto, who was a surgery resident who described this disorder back in 1912. He had 4 women of middle age who had enlarged thyroid glands. They were severely hypothyroid, and pathologically the thyroid gland was characterized by shrunken atrophic follicles and infiltration of the gland with lots of lymphocytes. And so he called this disorder struma lymphomatosa. He published in German, so struma lymphomatosa. But somebody gave the acronym Hashimoto's disease, and that made him famous. He actually, poor Dr. Hashimoto, 10 years after publishing his paper, he died of cholera. Ooh, boo. Occupational risk for doctors, guys. Anyway, the natural history of you think it's simple. I'm being a doctor sometimes. Anyway, the natural history of Graves' disease, somewhere around, of those patients who are in remission after anti-thyroid drug, those 50% of patients who are in remission after anti-thyroid drug, if you follow them long enough, 25% of them will eventually become hypothyroid. It's because the autoimmune process has burnt out the thyroid gland. And conceptually, you think of it as these patients have developed Hashimoto's disease. Now, conceptually, Hashimoto's and Graves are thought as opposite ends. But they're really a lot closer than most people realize. That when you look at a pathologic specimen of a Graves gland, it often has Hashimoto's mixed in with a lot of lymphocytes. Whereas in some patients with Hashimoto's disease will have circulating levels of thyroid-stimulating immunoglobulins. Go figure. But so they're 2 closely related disorders. In Graves' disease, you can think of it that the autoimmune process causing hyperactivity is ascendant, whereas in Hashimoto's disease, the autoimmune process causing hypothyroidism is ascendant. But often there's an admixture of the 2 disorders. Transiently, condition known as thyroiditis, an inflammation of the thyroid gland, can cause hyperthyroidism, hypothyroidism, and this most commonly occurs in the postpartum state after delivery. It's known as postpartum thyroiditis, typically transient. Iatrogenic causes of hypothyroidism, post-treatment of hyperthyroidism with radioactive ionomer surgery, or post-treatment of thyroid cancer. The therapy of choice is removed the thyroid along with the cancer. Transiently, iodine exposure can cause hypothyroidism. This is an internal regulatory process. It's known as the Wolff-Chaikoff effect. Wolff-Chaikoff effect, and it doesn't occur after you go to a sushi bar. Don't worry about that. Okay. What happens is that there's pharmacologic amounts of iodine administered, typically after a coronary angiogram, CT angiogram, or whatever. So this can lead to a transient decrease in thyroid hormone production. Thyroid hormone replacement therapy. Thyroid extract, thyroxine, triiodothyronine, or combined T4 and T3. Thyroid extract is natural. It's derived typically from pig thyroid gland. It's the oldest form of thyroid hormone replacement therapy that came online in the 1880s. The pig thyroid gland contains T4, it contains T3, and a lot of metabolically inert iodinated products. So it's a little schmutzy. It's a mixture of this, that, and the other. The major manufacturer of thyroid extract also brings you Armour Franks. It's true. The Armour company produces hot dogs. It also it produces Armour thyroid, which has the biggest market share of naturally occurring thyroid hormone. Philip Danforth Armour was a robber baron of the late 19th century. And he said he used every part of the pig but the squeal. Thyroxin, true. Thyroxin is the preferred thyroid hormone therapy. So if we have our druthers, we put the patients on thyroxin, which by and large is an inexpensive pharmaceutical. Triiodothyronine is used in some patients, typically as an adjunct with thyroxin, either alone or combined with T4 in a fixed dose. So, but it's a niche player. Most hypothyroid patients will be taking thyroxin. This is the pharmacokinetics of T4 and T3. The GI absorption of T4 is about 80%. So about 20% is lost to absorption, whereas T3 it's about 100%. And they're both are absorbed primarily in the jejunum. The half-time of circulation of T4 is much longer, of course, because it has less protein binding than T3. T3 is 0.3% free, T4 is 0.03% free. So T4 has a much longer half-time in the circulation than does T3. This prolonged half-time in the circulation of T4 leads to very small serum levels of changes in fluctuations of serum levels of T4, whereas very large fluctuations in serum levels of T3 occur because of the rapid metabolism. Head-to-head comparison. Thyroid extract is inexpensive. Some of your patients will like it because it's natural. But it has an imprecise dosing, meaning that from batch to batch, the amount of active hormone will vary. So there's wobbliness of replacement with thyroid extract. Thyroxin, the preferred replacement product, gives you constant serum levels. You determine the sufficiency of replacement by measuring pituitary TSH. If the pituitary is happy, you should be happy. And it's converted to T3, depending on the metabolic needs of the body, by the 5' monodeiodinase type 1 in liver and kidney. With triiodothyronine, serum levels are very variable due to the rapid metabolism. Remember, any patient taking T3 will have low T4 levels because of suppression of TSH. And you monitor, therefore, instead of measuring serum levels of T4, preferentially you measure serum levels of TSH, get the happy pituitary. T4 and T3 mixtures have been touted as improving the sense of well-being, not, because double-blind, placebo-controlled studies have shown that there's no advantage to adding T3 to T4. A patient can't tell the difference. You monitor the thyroid hormone replacement therapy by assessing the patient clinically for the signs and symptoms of the hypothyroid state, and biochemically, you measure TSH, the thyroid stimulating hormone. And the measurement of TSH should be made 4 to 6 weeks after adjustment of thyroid hormone dosing. That's to allow the pituitary to achieve a new equilibrium after changes in dosing. Pituitary doesn't change on a dime. Doesn't turn on a dime. And it takes 4 to 6 weeks to get a full equilibrium. The TSH levels should be within the normal range, and in patients who don't have a contraindication to full replacement, such as patients who who have, say, cardiac disease or unstable angina or tachyarrhythmia, the younger patient like you guys, you aim for preferentially for a TSH level in the lower half of the normal range. And if you do a good job, that's what happens, and that's our hypothyroid lady after 6 months of thyroxine therapy. So all's well that ends well, and thank you very much. You can
I'm sorry, I know you explained this, but could you just go over one more time why the anti-thyroid drugs are especially effective for autoimmune disease?
Yeah, because they don't. The anti-thyroid drugs apparently decrease the levels of the stimulating immunoglobulin for reasons unclear. They don't have a direct effect on decreasing the synthesis of the immunoglobulins, but in some way, by decreasing the thyroid hormone production, there's a decreased signaling of the thyrocyte to the immune system. So it sort of dampens the whole process and allows, and the idea of treating the anti-thyroid drugs is to allow the autoimmune process to run its course. But if it hasn't remitted, if the patient hasn't remitted, say in about a year and a half, 18 months, it's probably not going to happen. So we go on to the definitive therapy. Patients who have toxic multi-nodular goiter or toxic adenoma, these are not autoimmune disorders. You can keep a break on them with the anti-thyroid drugs, but they'll never, ever remit.
Thank you.
You're welcome.
Yes? I see you.
I was actually going to ask you about a son named Derek.
Yeah, I do. What?
He actually tutored the same person I did.
No.
And they told me to look out for Dr. McConnell and teaching me.
Oh, yeah, that's really funny. Where you tutor the same person where?
Through Cuda.
Oh, right, sure.
Yeah.
Okay.
Michael Vergio.
Okay, how cool is that? Oh, let's see, it's the...
But I want to say congratulations. I've never met him.
Oh, really?
I know that he got in.
Yeah, he'll be here he'll be here in August. Thank you. What's your name?
Nikita.
Nikita, okay, I'll pass it on. Okay, thank you. Pleasure.
sure the audio's on. Yeah, it should be still on because I'm not too sure, but I think the iCat people play a video. That's another reason why I want to come up here. But I just want to see if this audio works. Okay, that definitely works. Oh, crap. I forgot how to draw Krillin. Yeah. What was his specialty attack?
Well, in English it translates to destructo, basically.
All right. Let me see. What was Piccolo's?
Well, in English I think it was Wind Attack or something. Yeah.
Special Wing Cannon. Something like that, yeah.
In Japanese it sounds like it's
Something Wing Cannon. And Gohan was... What's Gohan? Oh, Masenka Blast. And Goku is the Kamehameha Wave.
What was Yamcha?
Who?
Yamcha.
Yamcha.
Dude with the scar on his
The
face?
triangle thing he used to do.
Triangle thing?
What was that?
It wasn't triangle.
His eye, right?
That's someone else. That's Ken.
Oh.
Yamcha's the dude with the scar on his face.
Right.
Yeah, the blue sidekick.
The one who like the
Bulma in the beginning.
And we lost that to Vegeta.
Yeah.
What was his?
I'll give you a hint. It had to do with summoning energy ball. It's homing energy ball.
He was the weakest one out of all of them.
Yeah.
Even the little
Krillin was stronger.
The little kid one was
yeah.
stronger than Yamcha.
Sadly.
Yamcha was like
The weakest one.
for real, the weakest link.
I thought it'd be Krillin, but he gained the powers like a Saiyan. Sort of. I think it was with the Dragon Ball or something.
I ain't gained powers of the same.
Oh no, it's the Piccolo, one of the dynamic people gave him powers. Something like that.
Gave Krillin powers? Krillin had power.
Yeah, but he got more power.
Piccolo got more power when he fused with Kami.
This left side keeps getting cut off. You see the C in the control
Adobe,
panel?
yeah. There's no remote down here, right?
No, it'd be in the boot.
Alright, so are we right black? What time is it? I don't think they're showing up. It says 11 to 2:30. They might show up at 12. Let's turn it off. Oh no, let me adjust this first.
Let me know and I'll shut it off.
Right now.